Welcome, everybody, to the Trauma Anesthesiology Society podcast. This is your host, Kevin Blaine. I am a trauma anesthesiologist at Oregon Health and Science University. Josh Sappenfeld is away this week. Today's discussion is the second part of a two-part series on the management of acute rib fracture pain. We will be discussing three innovative trunk blocks for rib fractures: the erector spinae block, the serratus anterior block, and the subpectoral block. I want to thank our partner Doc Matters for hosting our discussion and for creating this platform for us to communicate the science of trauma resuscitation to our worldwide community. I'm joined today by our two panelists. Dr. Jerry Jones is an assistant professor and the division chief for regional anesthesia and acute pain medicine in the Department of Anesthesiology at the University of Tennessee Health Science Center in Memphis, Tennessee. He has consulted nationally for industry as a key opinion leader and has served on the Committee on Regional Anesthesia and on the newsletter committee for ASRA. Dr. Jones was part of our panel discussion for part one of this series. Dr. Riva Ramlogan is an assistant professor and the Regional Anesthesia and Acute Pain Medicine Fellowship Director at the University of Ottawa. He is also the Vice Chair of Education for the Regional Anesthesia Special Interest Group at ASRA. The Ottawa Hospital is a Level 1 adult trauma referral center for Eastern Ontario. So let's begin. First off, I just want to clear the elephant in the room. Gentlemen, how strong is the evidence that supports the use for these alternative trunk blocks for regional pain?
I'll start with it. I think that is the obvious elephant. They are being used all of these nerve blocks are being used at various centers, but the literature, we're still early in that exploration. There are a number of case studies, case series, some small prospective comparison studies, and there are a number of cadaveric dissection studies that have where authors have indicated a variety of techniques and outcomes that are positive, but these are not techniques that have been thoroughly studied throughout the literature.
I agree with Jerry. There hasn't been a lot of robust studies done. There have been some RCTs for the ESP block that compared it to no block or another fascial plane block, such as the PECs or the SAP, in a variety of procedures, but there haven't been any randomized controlled trials specifically looking at rib fracture analgesia with these new techniques.
So it sounds like the evidence is not especially robust. We're probably not ready for these blocks to enter routine use just yet. But that does not mean that talking about these blocks is speculative medicine. Actually, it sounds like we're on the cutting edge of regional anesthesia for rib fractures. Would you agree?
I absolutely agree. Again, we need more studies in the literature that prove everything, but there is an enormous amount of clinical evidence. I mean, I guess we use these procedures all of the time, so it's exciting to be on this edge of it, but it's also frustrating to know that colleagues and people from a distance will just say, "Well, that's anecdotal,"
Well, let's discuss the first block. Jerry, in our first episode in this two-part series, you mentioned your experience with the erector spinae block in Memphis. How is this block performed?
Well, generally, it's you have to get to the patient's back, which is sometimes one of the troubles. But we will most often stay in the sagittal plane, find some area that's in sort of like you would pick a level for thoracic epidural. And then what I recommend is starting laterally where things are very obvious and easy: skin, subcutaneous tissue, ribs, and then slide in medially. Then you see the rib going deeper, you see the transverse processes flatten out, and then a lot of textbooks or a lot of authors will say go straight to the transverse process. And I think that's a fine way to do it because you have an obvious end point, and especially if you're not confident about your needle placement. If you go down and touch something, I think that helps. But what we find, because all of these that we do are with 2E needles because we're sliding catheters in. What I've actually found is it's optimal to tilt the probe back and forth until you can see the bottom of the ESP muscle optimally, and then slide just past the transverse process and inject and see that plane open up, and then sort of drive the needle into it just a little, and then aspirate and inject all the way along. That you can certainly do this transverse, but what I found in the transverse orientation, but I found that they don't spread north and south as well as you might want. I mean, that's the general gist. I mean, it's probably a lot like when you decide to do a paravertebral, except that you don't have to aim at a very deep, smaller space to go after.
What sort of coverage do you get with this type of block?
With ESPs, and again, when we say ESP, there are all kinds of the paravertebral lamina technique, a retrolaminar block, the thoracolumbar interfascial plane. There are lots of these things that are similar. And I know there certainly is debate among different camps about what the mechanism of action is, but I can tell you that routinely, when you put these blocks in, you're going to get essentially the same coverage that you're going to get from a paravertebral block. Now, my experience says it's not quite as dense as a paravertebral block, but there have been plenty of times where we see somebody that has rib fractures, then they go for a VATS or a thoracotomy, think, oh no, we're gonna have to pull that out and really put a paravertebral block in, but we can't, just time doesn't allow us. We bolus it up, and they do quite well. No narcotics, deep breathing and coughing, and we find, we check all of our blocks, are they working, how much, how well, where is your pain? And they all, to a degree or another, however wide, will have a decreased temperature sensation anteriorly. So it's hard for me to think that that's because I've put so much local anesthetic that spread all the way to the sternum. But, we get anterior, so we get posterior, lateral, and anterior coverage pretty routinely.
This sounds like a very strong block then. I wonder, are there any concerns with anticoagulation or the coagulation status in a trauma patient for placing this?
Not nearly like there are with epidurals. Again, you're putting it through skin, subcutaneous tissue, and one muscle. So, and if you look, ASRA guidelines for superficial blocks, this really widens the course. It really gives you a lot more opportunities. And, as it goes with all the other things, if you go just a little too far, you're still in a significant distance away from the lung. And it's been lots of people on my staff, I've had to train them up from no ultrasound use at all. And if you think taking that person who's in practice and you're going to suddenly get them to do paravertebral blocks, it's almost, it's impossible, or it's just going to take a really long time. ESPs, it's really a simple view, the sonoanatomy. So it's taken off. I've been able to give people just a basic amount of training, and people can routinely pick this up. The other point I want to make about it is, again, the textbook when people talk about exactly how to do it, go get right onto the transverse process, touch the transverse process. And I told you one of my tips and tricks, but I can also tell you with training lots of different people, sometimes we're a little bit more lateral than the transverse process. Maybe we don't realize it then. And they're relatively forgiving. Or if you get not all the way under the ESP, but maybe just inside the epimysium or something like this, still, we still get reasonable spread. And I'll tell you one other point about it that I'm noticing. A paravertebral block, when you pick your spot, I'm going to go right here. You have your spread, whatever dermatomes, 5 or 6 or so dermatomes, and it's there. What I found with ESP is they tend to spread a lot farther. It's more like that corridor is much more open, but the downside of that, so it's great if you've got 10 rib fractures, but the downside of that is over time, it seems to spread farther with gravity. So someone with a great spread, in the middle of their chest where everything is, at some rate, some period of time later, you'll see it sort of slowly sink down, and their abdomen is terribly warm, and it's cold at the very top. So,
Riva, do you have much experience with this block?
No, and I've tried it, but I wouldn't say I have a lot of experience. There's a lot of literature. The literature has just exploded about this block. It's being used for so many different things. And it's like Jerry says, like it's very easy to learn, and the big advantage over the central neuraxial traditional blocks is that anticoagulation apparently is not a concern because it is considered superficial.
It's not uncommon, and I'm sure it is in everyone's institution who might be listening, where you have a patient that has, here are their injuries, that's exactly what it is. 2 days later, you find out, oh no, there really was a carotid dissection, or oh, they do have a pulmonary embolism, and suddenly you walk in and they're on IV heparin. If you were using thoracic epidurals all the time, I think it would make people very, very anxious. But when you're using these different nerve blocks, when the game can change so quickly, it's a nice. But it's a lack of a lot of concerns that you might have otherwise.
Riva, in Ottawa, you guys are using a lot of serratus anterior blocks. Can you describe these blocks for us?
Yeah, sure. And that's one of the reasons why I haven't been doing ESP blocks. It's because I find the serratus anterior plane blocks are working for every rib fracture pattern, whether it's anterior, lateral, or posterior. One of the advantages of the SAP block is that the patient remains supine. So I don't have to worry about having the patient sit up or turn lateral and getting into a pain crisis. You simply abduct the arm to access the anterior to mid-axillary line. And for all of these fascial plane techniques, you want to put a catheter. And so your catheter should be placed at the mid-level of the range of fractures. So if a patient has fractures of ribs 2 to 8, then you place it at about rib 5. It doesn't really have to be exact because you're relying on fascial plane spread, which requires a large volume of injectate. You begin basically like how you would do an infraclavicular block. You use a linear probe, place it longitudinally at the midclavicular line to visualize the axillary artery and vein. And these vessels overlie the second rib, so then you can start counting down the ribs from that point. And you're rotating and sliding your probe along the groove between the shoulder and the pec muscle into the mid-axillary line. And your needle insertion, or at least the way I do it, is from cephalo to caudate direction. And I actually go down to the rib. It's been described to go either above or below the serratus muscle, but I use the rib as my endpoint, my target. I don't have to worry about trying to find different muscle planes in somebody who's had a traumatized thorax or has a hematoma or subcutaneous emphysema. And it's safe to hit the rib. And it's easy. That's how I teach my fellows to do it. And similarly, like what Jerry described, I try to get underneath that muscle and hydrodissect the plane to provide room to thread the catheter. So after you get under the muscle and you hydrodissect with a few mils of fluid, you thread your catheter, and you want to inject about 30 to 40 mils of local anesthetic. Until a few months ago, we felt that this block was limited to just anterior and lateral fractures. At least the literature presented it that way. But at the Ottawa Hospital, we found that it was actually working for posterior rib fractures as well. And we recently published a case series of these, but I still couldn't really understand how it was working. The premise was that it blocked the lateral cutaneous branches of the intercostal nerves, which supply the lateral part of the chest. But a recent cadaver study showed that in rib fractures, the local anesthetic, or the dye in this case, actually travels through the traumatized muscles and gets down to the intercostal nerves. And so this is probably why we're seeing such good spread, and why it's working regardless of the fracture pattern.
That's absolutely fascinating. It sounds like you do these as single shot blocks. What kind of local anesthetic are you using?
Oh, well, I wouldn't do a single shot, but yeah, if you were to do a single shot, then you need a large volume to get spread. It all depends on how many ribs are broken. But in general, for all fascial plane blocks, you need 20 to 40 mils of long-acting local anesthetic like ropivacaine or bupivacaine. We do 0.25% to 0.5% ropivacaine, about 30 cc's, and then run an infusion of it. The max we can run is 8 mils an hour with a 8 mil bolus size.
Interesting. So is this what you would call a volume block?
Yes, absolutely. And I think, Jerry, you'd agree that like all fascial plane blocks are volume blocks.
Right, and honestly, I think to me that is the biggest part that we need in the literature to say what is the right amount, or what are right amounts, and how far do they go? Let's really define these for different problems, rib fractures, breast surgery, whatever it is, and it certainly is volume that gets to the area. When we do serratus, or really it's we always aim at going deep to the serratus, although like Riva said, it's been described as going superficial. What I have found, one, the advantage he just mentioned is people with rib fractures don't necessarily want to jump up and move around for you. So laying flat is a huge advantage. What I've also found is that, they a lot of times have a lot of subcutaneous air. Sometimes it works to your advantage. Most of the time it works against you. But because of that, and you've had to kind of move around, I have had approaches where I go, where I see, just the rib, and, like all the way across the screen, whatever orientation you're in, and then try to slide it on top of the rib. Sometimes I then slide it over so I can see the serratus and the intercostal muscle and just drive it between there. And then you can also do it, where you see rib across the screen, and go and touch the rib or touch in between. I think any of those, and what I have found is that whatever orientation you're driving the needle, if you get it under the muscle, it's like a protective dome. It spreads in that area. And you're talking about how what is the cutting edge? Look, it's great that I'm listening to someone else who does it a little bit different than me. We tend to use, when we do a serratus, we use 15 or 20 cc's of 0.5%, and that dramatically catches the lateral aspect. And I'm always wondering, how do I define how far around will it go? I mean, the back edge of the serratus, muscle, it goes around. You could, go around farther. And I always wonder, how far can I get around with that? And I can't say that I know what it is. And then what you're saying is you use 40 cc's and you just go, yeah, it gets everything. What we do when we have lateral and anterior fractures, if it's posterior, you got to get to the back one or the other. That's what we do. But when somebody has anterior and lateral fractures on one side, we'll do a serratus and then do a subpectoral block and put it on a splitter, or maybe have it separate so that they don't have to move. So maybe I need to catch up to Riva and use 40 cc's and get everything in one, and I don't have to roll anybody over.
I think there's still like a lot of things we don't know. Like
Sure.
how is it spreading back there? Maybe gravity has an effect as well as the tissue disruption.
Right. When I compare these, when I came to this hospital, they were using the rib soaker technique. It's numb up the skin, go down, cut down to the rib, and take this metal rod and kind of push it down the ribs, and then put a catheter in there. And what I found is those almost always, they clearly were most of the time working by diffusion, because best case scenario, you put it outside of the rib and it would diffuse, and we'd find they'd have decreased temperature sensation posteriorly, not around anteriorly. So I was like, well, there it is, it's leaking. And sometimes it accidentally went into the ESP muscle itself. But on occasion, I would be surprised, I would actually see they would have anterior spread. And so what I think, the ESPs are doing is, for example, they're getting to the right plane, and it's not just diffusion. There's a big difference between those two. But what's really happening laterally? I mean, is it that it diffuses through the external intercostal muscle? Is it catching the branch, as it comes between the serratus and the external oblique, and riding backwards? Yeah, those are some, I think, still some unanswered questions.
Jerry, I'm glad you brought up the topic of the subpectoral block. I'll be the first to plead complete ignorance of this particular block. Maybe I need to brush up on my regional anesthesia skills. What can you tell me about this type of block?
Well, I'll start out by telling you about this one. It was almost the same as the serratus and the ESP. The sonoanatomy of all three of these blocks are very, very similar: skin, subcutaneous tissue, muscle, ribs below. So if you think all we're doing in one mechanism or another is catching the anterior intercostal branches as they exit through the external intercostal muscle under the pec major muscle. So, you're just going to, and we use it all the time for sternotomy or anterior rib fractures and that sort of thing. It looks like the way people describe it, they're very similar, but our technique is to go, we identify the sternum, slide over laterally to identify the pec major, a couple of centimeters, and we try not to ever go in the muscle any more than we absolutely have to, but just try to drive the needle over the ribs and inject and spread and inject and hydrodissect along. It is also described, though, by Raza when he talked about with rib fractures. I think it was a case study, and he just went basically straight through the pecs to land in that space between the pec major and the intercostal muscles. So, we try to keep the needle, again, same thing in the sagittal orientation, and try to center it close to where the ribs are broken. But I can tell you, we tend to use something like 10 cc's per side, maybe 15 for some reason. But with 10 cc's or so, you can get the full sternotomy sort of spread. And of course, you have to do it on both sides.
So, Jerry, are you aiming at the rib, or are you aiming for the intercostal muscle?
I am aiming at the space between the two, and if you have done some of these, the pec major muscle on the top is smooth, big, long, straight line. But just like on the serratus, the bottom of the pec major is not a flat surface. It kind of dips down and up and down and up. Down between and then over the rib and down between.
Yeah.
And so it's really about getting in that plane. And what I thought from the beginning is you've got to traverse each of these ribs to go all the way up, but you absolutely don't have to do that. What I've found that I tried to regularly get across at least 2 ribs, but even then, sometimes it's just not possible for various circumstances, and we just put it in one place and inject. And sometimes, a lot of times, we use at the end of the block, or when we're pretty sure we're in the right place, we'll inject some air to watch the air kind of shoot in a big line and say, okay, I know I'm in the right place. And I've done that and said, well, I can see local anesthetic spread up this far, but then you see the air and it goes way even farther than you can see. And then, of course, when you test people routinely, you can get all the way up to the collarbones with something like that, 10 cc's or so.
That's absolutely fascinating. Let me ask you a couple of questions. We've sort of discussed the issue of anticoagulation or with coagulopathies related to the trauma. It sounds like that's less of an issue for these trunk blocks, but I wonder about the risks of pneumothorax. I wonder about the risks of nerve injury, of vascular injections, of respiratory compromise from hitting some of the accessory muscles. Riva, what's been your experience with these sorts of complications using these innovative blocks?
Certainly, before you put your needle in and you're planning your needle trajectory, you want to put the color Doppler on. Like with the serratus anterior plane block, there's the thoracoacromial artery between the lat dorsi and the serratus anterior, so you want to avoid that. I only know of one case report of a pneumothorax from an ESP, but then again, there's publication bias, right? Anecdotally, I would say it would be very rare to get into any kind of trouble with bleeding. Pneumothorax can always happen if you don't know what you're doing, or you're not targeting a bony structure.
Right. I think it's rare. I think it's interesting to say, well, compared to other locations, they talk about the intercostal blood supply is so dramatic. Are we at, compared to other locations, could we possibly be at an increased risk of local anesthetic systemic toxicity? I don't see that that's borne out. And I agree, if you take an appropriate trajectory for your needle, especially like say when you're talking about subpecs, you should be going straight across the top of the ribs. You shouldn't be, it should really be hard to get down into the lung, but it's certainly possible. Now, keep in mind as you're learning these techniques, subcutaneous air gets in the way sometimes, but the other is sometimes people already have a chest tube. So, right. I'm not saying just go out there and go crazy, but I think you should be careful about if you went just a little deep, maybe if you drove a lot of local anesthetic into the intercostal muscles, maybe the blood flow is higher there. We don't really know clinically if that really makes a difference. But really the likelihood of having troubles with these is relatively low. And if you compare that potential risk, now again, don't do anything you don't know how to do, but even when things are more complex, you got a patient on Plavix, what should I do? Remember, these are rib fractures. People get pneumonia, they go on the ventilator, and they die from rib fractures. And it doesn't have to be 16 rib fractures. So to me, when we're weighing the risks and the benefits, again, don't go hog wild, but remember, if we don't do the best for these patients, they're going to end up with the pneumonia and they're going to die. So to me, that kind of leads my end of that tells me how I should weigh all of these things.
Are there any contraindications to placing these blocks?
Patient refusal. I feel a lot more open about again, I'm going skin, subcutaneous tissue, maybe not even through a muscle. And I have done it with, there are ways to go about it where you don't even really get into a muscle. I've done it with people who are on heparin. They're very superficial, and so I think where you have to be careful is when there's a lot of subcutaneous air, and keep this in mind too. When you're doing an ESP, it's relatively straightforward. It's like there's the target, go get it. When you're doing a subpec, the patient's breathing, so there's a little bit of movement. And the one that is the worst is the serratus, because when they're breathing, there's a lot more movement to that. So you really have to time yourself, or you're going to kind of chase your tail, or you could lose your needle very easily. Mm-hmm. And you may not be able to see as well as you think you can if there's a lot of air.
Riva, are there any concerns that you would have? Or are there any reasons that you might not want to do one of these blocks on a patient?
Initially, I was concerned with ESP and anticoagulation, and so that's why I never really tried going back there to close to the central neuraxis. Like a lot of these patients are anticoagulated. But I think the expert opinion now is that it's pretty safe, it's superficial. The odds of hitting a vessel is very low. And if there was some bleeding, pressure alone should cause hemostasis of it.
Sure. And all of these places are compressible. So
yeah.
Well, it sounds like these blocks are fairly safe then. It sounds like they have a lot of potential for as therapeutic adjuncts for rib fracture pain. Of course, the problem with this, as we've mentioned, is the fact that there's not a lot of data that supports it at this point. So I wonder briefly, and I mean briefly, we could talk about this for hours, I'm sure. What sorts of studies should we look for that would convince us that we should be using these blocks?
So ideally, you'd want multi-center randomized control, but this takes a long time. So the next best thing would be to have more practical studies like observational studies or database studies. But also we should look at not just the analgesic efficacy, but other factors that are important, such as non-pain outcomes, like how easy is it to perform? Like, do you want somebody with a rib fracture sitting on the floor, pressing the PCA and in pain and becoming hypoxic and going to get a pneumonia while they're waiting for a regional anesthetist for 2 or 3 days to come by? So the ease of performance is especially important because then a block can be performed sooner. The safety profile is also important, and from our discussion here, it sounds like it's very safe in comparison to an epidural with its risk of hypotension and bleeding. And then the ease of maintaining these blocks is very easy. There's, I would say, no effect on your blood pressure per se. So it isn't a big burden on the nurses. And then the patient side effects are practically nil.
Mm-hmm. That's interesting. Jerry, what do you think? What studies would you like to see that would convince skeptics?
Yeah, I agree with all of this. Now, you can, or you will see, some hypotension with ESP blocks. Although some people don't, believe that it's really going into the paravertebral space. We have seen that with bilateral ESPs with higher doses. To me, it's about making sure that you're comparing it to something people recognize, right? So if people know a lot about thoracic epidurals or paravertebrals, again, those blocks have failure rates and they have complication rates and a lot of reasons why you can't perform them. So to me, it would be finding the opportunities when you can, so that you can compare these, apples to apples, or we know what the apple is anyway. And then I would look at finding, find lots of databases, but I would find circumstances where you have multiple rib fractures, because 3 or less ribs, or sometimes even you have several, they're not displaced, or so making sure that it's something substantial, greater than 3, or I would even say greater than 6 rib fractures, because that's someone who's very likely in pain. I think it would be optimal if those studies also specifically graded the rib fractures. And then you want to also make sure that these are, for example, isolated chest wall injuries. It's not fair to, 6 rib fractures, but you also have a femur, right? That's too much of too many things out of the way. And I think the things we've already said, what is the analgesic quality per given dose, right? Because you could do a thoracic epidural with, 10 cc's an hour or something, but if you did bilateral serratus with bilateral subpex, or Riva's convincing me that maybe I should just use bilateral serratus blocks, that might be more. I mean, we run our subpex at 6 or 8 cc's an hour, serratus at 10 or 12. Plus a bolus. So looking at those sort of things, I think would be important, to help people decide when to use them. But I think the practical point of it is, who knows how to do these nerve blocks? Who can learn to do this? Who can go out there with a reasonable amount of time and training and become proficient so that they can make a difference? And I think the outcomes you would look at would be very clear things like, incentive spirometry, ability to cough, opioid use, and I think other pieces that should come out in studies when you're really comparing them, or under what circumstances can you use them? Because as we've kind of described, you can use them just about. I mean, it's rare to find a time that you couldn't use them. So those are some of the directions that I think where the literature needs to fill in a little bit more.
Well, thank you very much. That's helpful. I'm hoping that this conversation will trigger some additional studies in this area, because it sounds like this is an area that's ripe for new investigation. I want to thank both Jerry and Riva for participating in this conversation. Jerry, do you have any final comments?
Here's what I would like to say is people are considering, and maybe reasonably a skeptical audience saying, could we go into this? We've got thoracic epidurals. We know about those. We have paravertebrals. What are these crazy new things? Can you imagine it the other way around, where we really have been doing ESPs and subpecs and serratus blocks for 20 or 30 years, and then someone went the other way around and said, hey, I want you to take this needle and blindly stick it right towards someone's spine. Be careful if they're bleeding. Can you imagine how hard it would be to convince people to stick a needle in someone who's under general anesthesia, or can you just imagine it the other way? And so when I say that, I hope that a little tongue in cheek, but to say, find opportunities to go out and do some of these things, even if it's putting in single injections so that you can get someone comfortable enough to sit up to do your thoracic epidural, and find out. This is, I don't think experimentation is the right word to say, but this is not something that's really hard or likely to be a dangerous thing to go out and get your feet wet a little bit on. I would encourage people to climb in a little bit.
Riva, do you have any final thoughts?
Yeah, I agree with Jerry. A colleague in Calgary did an editorial on these blocks recently for Canadian Journal of Anesthesia, and he described these blocks as minimally invasive regional. So we all know the benefits of minimally invasive surgery, and it's pretty clear cut, right? Everybody can appreciate that. And so if you think about these blocks and you compare it to neuraxial blocks, they are minimally invasive and pretty easy to learn. Yes, we do need some more data, such as the optimal volume to use and the optimal bolus size and how often to bolus. But I think that data will come. These blocks are here to stay.
Thank you very much, everybody. This has been the 4th episode of the Trauma Anesthesiology Society podcast. As always, if you have any questions or comments, please leave them below in the show notes, and we'll try to respond to them as soon as possible. Thank you, everybody.